For that introduction, and thanks for inviting me here to talk to you today. What I'm just going to talk about today is some very early results from a London Joint Working Group project that I've been involved in with Emily and Dee Cunniff. The aim of this project is really to identify obstacles that are being faced by ODNs in trying to meet their hepatitis C sequence targets and potential strategies for overcoming these, with particular reference to data sharing, how that might be a help or a hindrance, and how that might impact on case finding. We're also hoping to identify any ways in which PHE could provide further information to ODNs to support them in this task. We're conducting a number of interviews at the moment with stakeholders from London-based care providers, including people with experience in information governance and data sharing. We hope to have the report out in early 2019. So today I'm just going to present some very early interim results from the work. So in doing this project, we're trying to look at information sharing between a number of different care providers. We're looking at community drug and alcohol teams. We're looking at secondary care and ODNs, primary care providers, and then also the relationship with Public Health England. So far, we've done a lot of work talking to people from community drug and alcohol teams, so that's the green dots and arrows. We've been looking at how people request and obtain information about hepatitis C diagnoses, how that information is passed on, both to Public Health England, but also to ODNs, and then how they interact with secondary care and how they receive information back from secondary and primary care about treatment progress or disengagement. The blue dots and lines represent secondary care, so we've been investigating how they receive information from primary care and community drug treatment services and how they share information back with them and how they interact with Public Health England. We've also been looking at what Public Health England needs from care providers and what they could provide back to care providers to support them better in identifying and treating patients. We also want to look at primary care, but we haven't conducted any interviews in that area, so I'm not going to address that today. So from the interviews that we've conducted so far, there's sort of four main themes that have currently emerged. The first has been a degree of confusion over who should be meeting the mandatory reporting requirement for letting Public Health England know about hepatitis C diagnoses. But in addition to that, it seems that a number of the ODNs aren't necessarily receiving this information either, which they also need. There are some potential problems about referring people for treatment in secondary care, partly due to variations in the type of referral systems that people have, so manual versus electronic. One of the major problems that has come up time and time again is how to share information between care providers. So, as I'm sure all of you are familiar with, different care providers have different electronic patient record systems, which can create big problems in terms of sharing information. It can lead either to missing data or it can lead to duplication of effort as people try to make sure that information is replicated across all of the systems. What that seems to mean in practice is that a lot of this information being transferred is reliant on personal relationships. So literally knowing who you should be able to pick up the phone and call if you want to find out more about patient progress or if you're concerned about disengagement from treatment. That's obviously a key potential point of failure because people move on or they go on holidays and then this information sharing system breaks down. Something else that has come up quite frequently is an eagerness to get access to the information that Public Health England holds on people who have been diagnosed but not treated with hepatitis C. That's moved quite rapidly as this project has gone on and even since we made these slides, and that Public Health England are now going to be sharing this information with ODNs, and the decision has been taken that this will be done, at least for the first phase of this re-engagement exercise, by contacting people through GPs. So I won't say anything more about that here. We need to see how that unfolds. So in addition to having a look at some of these potential obstacles, we've obviously also been interested in trying to find out how people have tried to solve these problems, both things that they've tried already or things that they're looking into doing. In terms of the reporting of hepatitis C test results, there's a general recognition that there is a responsibility for a medical practitioner to report this information to Public Health England, but there seems to be differing opinions about who that medical practitioner is. So whether that's the person who requests the test or whether it's the director of the lab that actually conducts the test. Regardless, everybody that we have spoken to so far has a good understanding of this responsibility, and they are clarifying with the labs that they use whether they have a reporting system in place, or if they don't, working with them to develop that or moving to a different provider. Public Health England is also working with the private labs to ensure that they have appropriate reporting systems in place. What we are going to look into further is whether these pathways for reporting to Public Health England could also be harnessed to report information back to ODNs about test results. Something else to investigate that some people are looking at doing is developing data warehouses to provide a repository for this information that would allow them to generate reports for ODNs to update them on test results. In terms of referral to secondary care, I think most people who don't have electronic referral systems, that will happen, although it will take time, but this doesn't necessarily overcome other problems with referral to secondary care, such as travel problems or concerns about stigma. The emerging consensus that seems to have come from our conversations with people is that outreach treatment, as well as testing in community drug and alcohol services, does seem to be a potentially effective solution to this problem. There's also the possibility of extending this type of outreach model to other contexts like community pharmacies. If that goes ahead, the one concern that does need to be addressed is whether this could lead to a further fragmentation of data sharing between people who are doing testing and treatment. And so we need to make sure that there are robust strategies in place to ensure that data is collected securely and transferred appropriately. The biggest issue that comes up is the fact that different care providers have different electronic health record systems, and this is a problem across all of the NHS. It's an endemic problem. Unfortunately, the use of the outreach model doesn't completely overcome that problem, because it just means that outreach staff have to enter the data into multiple systems to ensure that it's propagated to everybody who needs access to it. Something that some people have access to is a local care record, which permits sharing of entire medical records between primary, secondary and community care providers. But this is something regional, it's not something everybody has access to. And it's not an alternative system, it's a read-only system that sits alongside people's current patient record system. An alternative to this that people are investigating and looking at doing is just sharing data that is specifically relevant to hepatitis C testing and treatment between care providers. But there seems to be a lot of concern about whether this is something that is actually permissible under the current data protection regulations. From the conversations that we have had, it seems that when you are sharing information for the purpose of providing optimal patient care, and this is something that a patient might reasonably expect that you would be doing, that everyone involved in their treatment would have this information, then this is permissible under the current data protection regulations. And in fact, some people have said, well, actually, there is a duty to share this information in order to provide the best possible care for people. Obviously, that doesn't remove the responsibility for patient confidentiality, but the two things need to be balanced against one another. This can be something that can work within an opt-out system so that data sharing is the norm, provided that patients are given the option to refuse to share data. And where that's the case, they are told of the potential ramifications for their care if data is not shared, so how that might impact on delivery of care. So that's the theory. So in theory, this should all be feasible and permissible, but of course the practicalities of this are more complicated. So in order to share even just pieces of information about people's treatment, there has to be a clear specification of exactly what information is going to be shared, who is going to share it, and under what conditions. And the tricky thing is that everybody with whom data is shared has to meet NHS information governance standards. So that can require all of the organisations to actually demonstrate that they meet those standards, and it can require contractual obligations to do so. So all of that takes time and money to put into place. What we are intending to do with this project is identify and investigate case studies from other parts of the NHS where people have managed to put data sharing in place and see what lessons we can learn from this and how we can apply that to testing and treatment of hepatitis C. I I'd just like to thank everybody who's talked to us already and everybody who we've lined up to talk to us going forward, and also to say if we haven't spoken to you and you think you have an obstacle or a solution that you'd like to share with us, please do get in touch with Dee from the London Joint Working Group, and also to acknowledge that the funding for this came from a grant to the London Joint Working Group from AbbVie. Thank you very much.